Hey everyone, for this Rona rounds, we're going to do a sad but a very necessary discussion. I'm hoping that by talking about end-of-life care, it can ease some of the anxiety surrounding it. In the emergency department, we've all experienced informal palliative care, but in the upcoming months, we're likely to see more of it than we're used to. As an emergency physician, I am by no means an expert in palliative care, and many of the nurses I work with have much more experience than I do. I'm going to talk about some of the things I've been reading about, some of the experiences I have, but please put any suggestions or recommendations in the comments below. To start with, I want to talk about communication and compassion. There's been a lot of worry regarding compassion fatigue, but I just want to remind everyone that small acts go a long way. There's going to be time constraints, PPE barriers, language barriers that might prevent you from providing the exact care you want, but even the small things you do for people will bring a lot of comfort. Don't feel the need to be perfect all the time. Do the small things like use people's names, call their families frequently, provide a phone for the patient to talk to their families if possible. If a patient has a phone or a tablet but is unable to work it, consider having families record messages on them so you don't have to coordinate times for a call. Never underestimate the power of a warm blanket, a pillow, or a glass of water. Remember Vaseline for lips and sterile normal saline drops for eye lubrication. Try to minimize invasive procedures, reduce or eliminate vital signs. Think about crisis placements as they're less bothersome than IVs, and sub-Q medications can be given without repeat pokes. From a more medical management perspective, I just want to talk about some of the commonly used medications. Remember that not all physicians are comfortable with these medications or, quite frankly, remember all the time to provide them. So please remind us if we forget. Ask us to order them if they're not already done so. For dyspnea, the most common medication used is morphine. The subcutaneous route is preferred. We want to titrate people's oxygen and delivery methods for comfort, not for a goal SpO2. High flow nasal cannula often dries out nares, so people tend to tolerate masks better. The feeling of air blowing on a person's face can also help with dyspnea. Fans are commonly used in the palliative ward, but obviously for IPC concerns cannot be used in the emerge. But perhaps the oxygen from a mask can deliver the same comfort. For secretions, we often use glycopyrrolate and scopolamine. We would really avoid deep suctioning unless needed. For pain, again, morphine and dilaudid are the preferred medications, and sub-Q route is preferred as well. For agitation, often Haldol, sub-Q or PO is used, and Nausnan is used quite a bit on palliative wards, but isn't necessarily available in all pharmacies. Remember that controlling a fever can provide lots of comfort, so Tylenol, PO, or PR should be a PRN order for all these patients. Optimally, these patients will be admitted quickly to a family medicine or palliative care team, but obviously this isn't always possible, so try to make their stay in the emerge as comfortable as possible. See if you can get a hospital bed for them, as those stretchers are not very comfortable. Please feel free to share any thoughts or suggestions below.